Thank you for having me. My name's Gina. I'm a physiotherapist. I work at the Royal Free Fatigue Service. You can see on the slide there I work with Dr. Gabrielle Murphy and also in this study working with Dr. Kelly Morris. So today we're going to talk to you about an audit that we did looking into how many of the new patients that are presenting to the clinic with fatigue symptoms are actually more flexible than average. So they have this innate kind of stretchiness to their limbs and their skin and their soft tissues, and we were very interested in that, and we've got a poster here today, but we wanted to give you a little kind of whistle-stop tour through what we found. So hopefully I'll press something and it'll, not that one, that one. So we're a multidisciplinary team. Dr. Murphy is our lead, and there's myself and an exercise physiologist that cover the graded exercise therapy side of things. Dr. Kelly Morris is helping us with what we're doing, making inroads into research, and the rest of our team are psychologists. So the reason that we started to become interested in potentially doing an audit into hypermobility within fatigue. My background was as a musculoskeletal therapist, so I treated a lot of hypermobility. I've also done a master's in pain management, so I had kind of two different areas looking at persistent pain, but also the physical assessment of hypermobility, and then bringing that into the patients that we're treating with fatigue. But also Dr. Murphy was noticing in her clinic the number of people that were coming through and saying, look, I'm double jointed, my mum's the same as me, or my brothers are the same as me, and what have you. So we felt it was something we needed to look into in more detail. We talked through it at our multidisciplinary team meetings, and the outcome was we decided to audit to find out how prevalent joint hypermobility syndrome is in our clinic at the Royal Free, and we were planning to do that over 1 year. So just and apologies that it does feel like a bit of a whistle-stop tour, but I'm conscious of time. Joint hypermobility syndrome is one of what we call the heritable disorders of connective tissue. So it comes under an umbrella alongside other syndromes. Marfan syndrome, it's pretty much indistinguishable from the hypermobility type of Ehlers-Danlos syndrome. And obviously there are elements of hypermobility within osteogenesis imperfecta as well. It's inherited from, you pass it through your family, so you can nearly always find a relative, and this is where it was interesting in clinic talking to people. Oh yeah, you know, my mum's really bendy and my sisters are gymnasts and what have you. And what we're basically looking at is some faulty coding really for how collagen is produced, but also how it's organised, because that has a real impact on its function. And the main symptoms that people can present with is widespread pain, but also laxity, so the sensations that their joints can sublux and dislocate or feel kind of untrustworthy, like they can't have confidence in them. But we're not actually looking at rheumatological disease. Blood work for this patient group would be normal. If we were to put them through scanners, we wouldn't see anything untoward. But we do know that it's related to age, sex and race. So there are ethnic groups that are just naturally more flexible, Afro-Caribbean and Asian groups. Hypermobility diminishes as we age, and it's more prevalent in women. But I just think it's a really cool area. Being a physio, anything to do with the body, I'm in. But I just think when you look at what collagen does for us, it's massively interesting. Type 1 collagen is designed to withstand huge forces because its fibrils are arranged in parallel kind of bundles. So if you think about what it does in our tendons, it's fantastic. It forms scaffolding in our bones, and then type 2 collagen, because it's arranged in this kind of random mix mash in the proteoglycan matrix, it's designed to withstand compression, so that's how it functions in our cartilage and our joints. But if you imagine if there's more elasticity inherent in all of that, if the coding for how that's produced and how the fibrils are organised is slightly perhaps outside of the norm, then we can see some really quite profound symptoms. But the key message is that collagen is in every bit of us: skin, our gut, our blood vessels, bones, ligaments, tendons, muscles. So when we think about the symptoms that CFSME patients are experiencing, it makes sense that there could be some overlap with hypermobility. And we're just looking at the different glycoproteins here that can perhaps come out, be translated in a slightly different way. So we might skip a few of the little codes that would normally produce the type of collagen that we would expect, and we might end up with a much more stretchy collagen. Obviously, there are positives to that, but there can be negative symptoms as well, and that's where we want to get in and be able to target helping people. So from our point of view, we were brainstorming why it was important for us to identify perhaps subgroups of people that are coming into our clinic with fatigue symptoms, but also who have these hypermobility traits. And we feel that it's another layer. When we look at persistent symptoms, our assessment in our sort of professionally is becoming much more sophisticated and layered. So the biopsychosocial kind of assessment is becoming much more individualised to that person, and finding out about their own experiences and helping them to really understand their condition. And I feel it's another layer of that. My job is very much about assessing the physical side of things as well as the emotional and psychological, so it fits in with what I do. But I think it gives us a real route to be able to educate people better, and education gives them empowerment. I think if you're informed about what's going on with your body and why that might lead to X, Y and Z symptoms, then that's the first chance to be able to do something about it. And reconceptualising hypermobility can be a really big deal. How people view their joints, if they view them as untrustworthy, or they view them as extremely lax and vulnerable, that is going to feed into central sensitisation and potentially provoke more profound symptoms of pain and fatigue. So it definitely gives us opportunities, and it might give us opportunities to link with other specialist clinics more perhaps. So that probably is a bit difficult to read, but it's just a kind of list of all the different signs and symptoms that we might associate with hypermobility. So they're going to be more vulnerable to soft tissue sprains, but also dislocations, fractures, back pain, fibromyalgia, lots of different things there. But also we know that the GI dysmotility comes under hypermobility, autonomic dysregulation comes under it as well. So again, that's where I see parallels with CFSME, because the symptoms are so broad and body-wide. So the way we approached our audit was that all of the new patients that were coming through the clinic, which are GP referrals, were given a screening questionnaire. So there's a 5-point questionnaire that's designed to be sort of highly sensitive and specific to pick up hypermobility, and it's quick for patients to fill out because it's literally yes and no answers, and if they answer 2 or more, then they're likely positively, as in yes I do have those traits, then they're likely to be hypermobile. So we used that as an initial point in Dr. Murphy's clinic, and then we further assessed people physically using the Baton score. So this is the questionnaire. So can you now, or could you ever place your hands flat on the floor without bending your knees? Yes or no? Can you now, or could you ever? And that's the important thing, because it's still a yes if they could ever do it, okay, because of what we know about the fact that hypermobility does reduce as we age. Bend your thumb to touch your forearm. As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did you dislocate your shoulder or kneecap on more than one occasion? And finally, do you consider yourself double jointed? And alongside that, we use the Baton score, which is really quick. It takes less than a minute, if up to a minute, and you can run through it in clinic with patients, and you can score their hypermobility. We have to bear in mind that it doesn't take into account shoulders, hips, ankles. So it's another tool that you can use, but we've also got the Brighton criteria, which is another way of kind of strengthening your clinical findings. You've got major and minor criteria, and you can have a combination of both. It's explained to you in the actual criteria itself, so it's quite easy to use. But you can also assess people's skin, you know, the extensibility of their skin, even on the back of their hand. If you get them to pick up their skin and look at, does it stretch along its whole length? That is a good indication of what their collagen is like. Do they have any scar tissue? Do they have any stretch marks? Have they ever kind of struggled to recover from things like ankle sprains? Because we know that there is a delay in healing. So the results that we got, we initially planned a 12-month audit. I threw a slight spanner in the works because I broke my collarbone partway through that, so it wasn't there. But we had a 10-month audit in total, and initially 184 patients came through the clinic, 142 completed the questionnaire, so that was a 76% response rate, and we had to exclude 2 questionnaires that weren't completed fully, and we couldn't get a clear kind of result from that. So that leaves us 140. And we actually found that 47 of those patients fulfilled the criteria for joint hypermobility, and 93 didn't. I assessed 8 patients further using the Baton score and the things we've talked about, so taking a whole history, looking at their skin and their biomechanics, you know, what's their foot position like, and other things that you can assess. And in a kind of early analysis that we were looking at, if we assumed that all of the patients who didn't complete the questionnaire didn't meet the criteria for joint hypermobility, so that would give us 47 of 184, then we would actually be looking at a 25% cohort. So 25% of the people presenting to a fatigue service with fatigue symptoms in this little kind of chunk of time in one clinic are potentially hypermobile. And we thought that was a really interesting finding, because what it started to generate was questions of, okay, so what's the primary diagnosis here? Is it CFS-ME or is it hypermobility? So it started us thinking about what we could do in the future. we obviously need to investigate further, and hopefully other services can replicate the results, because that might strengthen conclusions. But we're going to carry on screening patients for joint hypermobility within our service. And what we're going to explore is our options for exercise, comparing different types of exercise prescription, because what we know in hypermobility is that there definitely are proprioception and balance deficits, and perhaps that needs addressing in how we prescribe our sort of incremental exercise when we're approaching fatigue. So from my point of view, being a physio, I would be interested at whether we could blend the two approaches. When I worked in a musculoskeletal physiotherapy setting treating hypermobility, we treat it with strength work and proprioception and balance work very effectively in adults as well as young people. And the reason for that is because you're then putting a different stimulus in peripherally and centrally, and you're influencing so many different factors. You're influencing people's confidence in their daily life and their functional tasks. You're reducing likelihood of unpleasant things like falls, which can really frighten people. You can explain that you're reducing their risks of recurrent sprains and subluxations, because stronger kind of muscular splinting around joints can help with that. But also it can help with some of the orthostatic symptoms that they might experience. If we strengthen their calves and their core, that might help them to actually reduce the impact of some of the symptoms they get when they change position, or when they get up in the morning, all of which can impact on their quality of life. So I think it gives us a lot of inroads to be able to make people's treatment very individualised, which obviously with a condition like CFSME, it isn't a one, and as people said earlier with pain even, it's not a one size fits all. It needs to be very much about what that person needs at that time. So I think it just gives us another opportunity for that. So sorry if I went through that 100 miles an hour, but I was a bit concerned about time. If anyone has any questions.
Gina, thank you.